The most important thing on any day at the clinic is this right here. Good old bulletproof coffee. All right, everybody, we have 3 procedures today. This is Fridays at RP. First one is a stellate ganglion block. Then we have PRP for some neck pain. So we're gonna be treating the facet joints. And then we have PRP for some ankle pain. So we just finished our first procedure of the day. We did a stellate ganglion block on the right side for this patient. The patient has a long-standing history of migraines that we've been working together for close to 2 years now, and we've made big impacts on the frequency and the duration of the migraines. However, recently we've kind of hit a little plateau, and so we look to doing a stellate ganglion block to help with that. So basically, under ultrasound guidance, we advance a needle on top of longus colli muscle, which is where the cervical sympathetic chain is going to lie. Technically, the stellate ganglion block is a misnomer because the stellate ganglion is actually at C7-T1 and the block that we do is actually at C6. But we get spread of the fluid downwards, which then allows the injectate to go over top of the stellate ganglion. And so what we're doing with that is when we block the sympathetic chain anywhere in the body, you're basically going to have a reduction in sympathetic outflow. And so we can use this procedure for anxiety and PTSD because we're actually blocking the connection from the brain down to the adrenal glands, so we're not getting as much adrenaline dumping when we have traumatic triggers and things like that. We can also have a overexpression of the parasympathetic nervous system, which will help with anxiety states, generalized anxiety, things like that. And then also sympathetically mediated pain and vascular migraines can also see positive benefit from the stellate ganglion block. So we can help with things like CRPS and other vascular occlusive diseases of the upper arm and also the head and neck. And so we will track this patient over the next few weeks and see how they do with their chronic migraines. All right, so we are doing some PRP processing here. So first thing we did was we drew 120 cc's of whole blood, and then we took a sample from that to send to the lab, and then we spun it down for the first spin in the centrifuge. The goal of the first spin is to separate out the red blood cells from the plasma. We're not concentrating the platelets yet, and so we do a lower RPM but longer duration spin, and what we end up doing is, let me show you here, is we get a separation of the red blood cells. Well, it's having a hard time focusing. The red blood cells from the actual plasma. So that is what we get after our first spin. All right, so our second case of the day on this brand new series that I decided to start today called Fridays at RP, but this is the first. This is the first Friday at RP. So we have a right-sided neck pain and also unilateral headache. So a patient is experiencing right-sided neck pain with headaches that are in basically the lateral aspect of the head, so the temporal region. Our physical exam basically was indicative of facet syndrome. So patient was better with flexion, was worse with extension, which when we go into extension, we actually close off those facet joints. And then our Sperling's maneuver, which is basically an extension, contralateral rotation, and then lateral ipsilateral flexion, reproduce the pain in her neck. And that maneuver compresses basically the facet joint maximally, which then is indicative of some actual facet irritation. And so what we're going to do is, under ultrasound guidance, we are going to inject into and around the facet joints. We're going to treat, so I'm assuming that hers is around C3. We always want to treat one above and one below minimum when we're treating the facet joints. So we'll treat C2, 3, 3, 4, 4, 5. When we're treating, I'm always making sure that I'm evaluating with the patient and getting feedback on pain, because if I do 2, 3, 3, 4, 4, 5, and 4, 5 is still painful, then I know that I need to come down to 5, 6, because the way that the innervation of the facet joints works is we want to make sure we're treating one above and one below the level of where we have pain. And so if we get down to 4, 5 and it's still painful to inject there and it recreates her pain, then we're going to inject 5, 6, and we'll continue down as far as we need to make sure we're treating the entire area. So that'll be done under ultrasound guidance. We're going to use PRP today. I'm going to concentrate our PRP to about 4 to 5x, and then also treat the capsule around the facet joint. And then we're going to we're going to swap. I said switch and swap at the same time. We're going to swap out and do platelet poor plasma into the multifidi muscles in the cervical region. We found clinically that helps reduce some pain from the patient, and also seems to help with some mild muscle regeneration, especially if there's some basically some fatty displacement or replacement of the muscles, fatty infiltration. That's the word I'm looking for. Infiltration of those muscles, which happens with long-term chronic pain because the multifidi muscles are not working as well. So platelet poor plasma does better than platelet rich plasma inside muscles, and so that's why we are going to be doing platelet poor plasma today, but we'll basically do that into the multifidi muscles. And then last is, because the patient has some generalized instability from an accident, is we're going to treat the nuchal ligament. The nuchal ligament is that big ligament that starts at the back of the head on the occipital ridge, and it travels down, and it ends up becoming the supraspinous ligament that is over top of the spinous processes in the thoracic and lumbar regions. But we're going to treat that nuchal ligament in the cervical region, both the superficial and the deep portions, to help basically bring a little bit more stability to the cervical spine, reducing that instability, so that long term we can reduce the potential progression of arthritis, because we know that anytime joints are damaged and there's increased motion in joints long term, we can have increased arthritis there. So that is going to be our approach for our second case of the day. So after that first spin, we then remove the plasma from the tubes, and what we are left is, so you can see here, we have the red blood cells with just a small little bit of plasma left over, and then this here is our plasma. Now we're going to spin down that plasma, and we're going to concentrate a platelet pellet that will reconstitute, and then we will inject it into our patient. All right, so once we are done with the final spin and processing, we are left with basically two products that we are going to use today. We have PRP here on the right, and then we have platelet poor plasma on the left. We're going to use the PRP for the joint injections, and then we're going to use the PPP for treating the nerves. All right, everybody, that wraps up our Fridays at RP. So recap, we did a stellate ganglion block for a patient who is having vascular migraines and a little bit of neck pain. Then we did a PRP for some neck pain. So we treated the facet joints, which went really well. And then we also, last case was we did an ankle PRP, and specifically treated, we did a nerve hydrodissection of the sural nerve, which is the main nerve that runs down the lower portion of the calf right over top of the Achilles tendon. So patients who have Achilles pain very frequently have some inflammation in that sural nerve. So we hydrodissected that. Then we put some PRP into the fat pad. And then it also appeared that the fat pad was sticking a little bit to the underside of the Achilles tendon, and so we hydrodissected that apart. And that's our Fridays, people. I hope you all have a great weekend.